We're going to go ahead and get started in just a few minutes, everyone. Thank you. All right, welcome everyone, and thank you for joining us for today's 2020 Medicare Update webinar presented by the AAA's Medicare Consultant Brian Werfel. We've got a lot of great content to go over today, so before I hand it over to Brian, I just wanted to remind everyone that if you would like to ask a question throughout the presentation, you can do so by using the Q&A button on your menu. We'll try to answer some of the questions throughout the webinar, but we'll also hold a Q&A if we have the time at the end of the presentation to go over any of the questions that we have not covered. If there's any questions left after the Q&A, we'll go ahead and post an FAQ up on the website so you can get the answers to any of the remaining questions. We'll also be sending out a recording of the presentation this afternoon, as well as the PowerPoint slides for your review. Without any further ado, I will go ahead and hand it over to Brian to get us started.
All right, thank you, Megan, and good afternoon, everyone, and good morning to those of you joining us on the West Coast. So today's webinar was scheduled a ways back, in fact, before the COVID pandemic really took over the country and took over sort of everyone's attention. So rather than sort of revisit the entire presentation, we made the decision to simply keep the presentation as it was, and then add in those items that have changed as a result of the COVID pandemic and the current national state of emergency. But given my expectation that most of the questions will revolve around the COVID issues, I'm going to sort of just try and go a little bit quicker than we might have otherwise through the non-COVID related Medicare changes. And again, just as Megan indicated, feel free to answer, or ask rather, questions in the chat box. I'll try and get to them as we go through the presentation, and time permitting, we'll have time for questions at the end. So with that in mind, my screen seems to have frozen. There we go. All right, a little bit of a lag there. Sorry about that, everyone. First topic I want to talk about is the ambulance inflation update. Just as a reminder, this year our inflation update was 0.9%. That is based on a 1.6% increase in the consumer price index over the period that started in July of 2018 and ended in June of 2019. And then from that 1.6%, CMS takes off the multi-factor productivity index, which was 0.7%, leaving us with a 0.9% increase this year. On this next one, what you're just seeing is the historic change over time, both with the CPI itself, that's that blue line there, the MFP is the yellow line, and then the gray line that's sort of between them is our resulting ambulance inflation update. One of the things, we tend to stress on this is that the CPI urban is not a perfect metric for increases in our costs, and then taking the MFP off that just simply means that structurally Medicare's reimbursement is not designed at this point to keep up with increase in your costs, and that's part and parcel of why long-term Congress has mandated that CMS move towards a different approach through the cost data collection process that we'll talk about in a little bit. This next chart just shows you the impact of that MFP on the ambulance reimbursement, your reimbursement. So what you're looking at here is a starting point of $350. For those of you in urban areas, that's roughly equivalent to a BLS emergency allowable. And then showing what the 10 years of the MFP have been, the impact on our rates. And what you're going to see is that it's had a sizable impact. Roughly about a quarter of the increases that we otherwise would have gotten as a result of the CPI have been eroded away by the use of that MFP. That gray line at the top is the CPI medical. That is the inflation metric that many other healthcare entities or providers use for their increases. And as you'd expect, that inflation update is significantly outpaced the general consumer price index over time. Just wanted to show the impact that other provider groups get with inflation. Turning then to Medicare payment data, what you're going to see here is this is total Part B payments. The Part A payments for ambulance are a little bit tougher to get at, but roughly speaking, it's anywhere from $250 to $400 billion in any given year. But what you're going to see is that as an industry, we have been fairly flat at just under $5 billion in total Part B payments for about 6 or 7 years now. And that's the result of sort of a number of different factors which have all sort of worked at cross purposes with one another. Every year we do get an inflation update, however small it may be. That's being offset in recent years by some changes to the reimbursement policies specifically for dialysis, and then some changes in volume, again, typically related to dialysis. Here we're looking more at the impact of prior authorization. But total revenues are flat is the key takeaway here. In terms of looking at the dialysis picture, they are not flat. They peaked in 2012, and then they've been declining steadily ever since. That's partly the result of Congress implementing reductions in the amounts paid for dialysis, originally 10%, and then an additional 13%, so that now a dialysis trip is reimbursed at 77% of what a similar BLS non-emergency would normally be reimbursed at. But it's also a function of a decrease in volume, and again, here you're primarily looking at the impact of prior authorization. Just to put it in sort of pie terms, dialysis was 10% of total Medicare spending on ambulance in 2015, before prior authorization really took hold. It's now down to 8%, so a 25% reduction in total dialysis payments, as a percentage of all spending. In terms of prior authorization, the program itself towards the middle of last year, CMS and its contractors started to pivot in a way that signified to many of us that they were getting ready to move forward with national expansion of prior authorization. So the first thing they did was both of the contractors that are previously implementing the demonstration project for prior auth, and that's Novitas and Palmetto, changed the period of time in which they would approve patients for. So originally it was a 2-month approval period with up to 80 one-way trips within that period. So they were thinking 30 round trips and then a little bit of extra just in case. But towards the middle of last year, they increased that to a 6-month approval period. Many of us interpreted that as their sort of clearing the deck and giving these providers some space so that they could take on additional states in their jurisdictions. Of course, a lot's happened since then. For what it's worth, I don't think I mentioned it elsewhere, but CMS has given Palmetto and Novitas the option of pausing prior authorization during the current health emergency. And what that really means is that while providers can still continue to submit for prior auth, providers can elect not to go through the prior auth process. Normally that would have resulted in them facing prepayment review of the claims, but now they'll just process them in the ordinary, course using their normal program edits to determine whether they pay or deny. Sorry, screen froze up again. There we go. They did extend the existing program for an additional year. What is a little bit different this time around is rather than use language that says, while we continue to study whether it makes sense to extend it nationwide, they sort of changed their guidance to this more affirmative statement that they're now moving towards national expansion. So for those of you that are not currently under a prior authorization regime, but for the COVID pandemic, the expectations that they likely would have implemented it starting next year in 2021. What impact COVID has on that sort of just remains to be seen at this point. They've also solicited comments on how they should go about expanding it nationally. So I don't think this was comments so much as do you think it's a good idea or not, so much as just talking about the actual infrastructure that would be required and then some of the procedural steps. So as an example, does it make sense to roll it out in Noridian's jurisdiction, every state at once, start with a few states and then gradually expand it while they move up towards a state like California, which is a much larger population than, say, Montana? Those comments have already been received. CMS will likely be publishing, when it gets a free moment, I imagine, the comments and their responses to them. Physician fee schedule that came out in November of last year had 2 important pieces for ambulance. The first is it finalized the rules that would apply towards cost data collection, and CMS has not, at this point in time, indicated that they intend to change that timeline. Towards the end of last year, they announced those providers that would be asked to submit cost data in the first round or the first year of cost data, and then also published additional guidance on what elements and how to complete it. AAA has been doing a lot of education on cost data. I'm sure many of you have been on other webinars featuring myself and Scott Moore, Kathy Lester, a bunch of other volunteer leaders with the AAA. I don't want to delve too deep into cost data here, other than just to say that as of today, there's been no change. So for those of you that were selected, you're still going to have to continue to track your costs so that you can report when the year ends. The other change they made was to the PCS form, and there's been a bit of, I wouldn't say confusion, but there has been a bit of sort of loose language around these changes, and it's unfortunate in that the way CMS did it. But for our purposes, it is largely cosmetic, the changes they made. They look much more dramatic than they are, but the key takeaway is that they did not in any way, shape, or form change when a PCS is required or who may sign the PCS form. So for repetitive patients, it still can only be signed by a physician. For non-repetitive patients, they did make some changes to who can sign. The cosmetic change is to basically reclassify the certification statement as either a physician certification statement or a non-physician certification statement, depending on who is signing it. So if it's signed by a physician, it is a physician certification statement in their new language. And if it's signed by any of the other individuals that can sign for non-repetitive patients, they're now referring to it as a non-physician PCS form, or the acronym NPCS. Now, the one substantive change they did make, and this is something that the AAA has been pushing for many, many, many years, is to add certain additional licensures to who can sign, specifically the LPN, the case manager, and the social worker. Now, I would argue that each of these individuals, when they are completing a PCS form, are already acting as a discharge planner. However, CMS, by adding the licensures, has eliminated the need to, now go into the issue of what their job title is. So, as of January 1, any of these three individuals can sign for non-repetitive patients. Probably the biggest change, and it's not new, it's about a year old at this point, but our industry is sort of trying to live through or learn about the implications, are these new changes to the SNF consolidated billing edits. So these are the result of an OIG report that was conducted over the course of several years, and it was issued in February of last year. Essentially what the OIG found was that when they looked, something like 78 of the 100 days they looked at where an ambulance claim was submitted for a patient in a inpatient SNF stay, the first 100 days of that SNF stay, that transport was to a service that would not be excluded under the SNF billing rules. And as a result, they estimated that there was about $20 million in overpayments. Their recommendation, which was ultimately implemented by CMS, was that they put in place new edits to prevent the Part B payment unless there's some vetting or verification that it was truly excluded. Now, the way those edits work conceptually is to staple your claim to the associated hospital claim, and they already have edits in place to determine if the hospital claim should be bundled to the SNF or not. Those edits basically work by comparing the CPT or HCPCS code on the hospital claim to a list of excluded codes. If the CPT code or HCPCS code on the hospital claim is excluded, they release the hospital claim for separate Part B payment. If it's not excluded, they deny it as the responsibility of the SNF. Now, your claim will go the same way the hospital claim goes. So if the hospital claim is excluded, yours will be excluded and you'll be paid separately by Part B. If the hospital claim is bundled, your claim will be bundled as well. But there is a timing issue that's associated with this. Specifically, in order for the edit to work right, both the SNF claim, so that they know the patient's in a SNF stay, and the hospital claim, so that they can look at the HCPCS codes or CPT codes on the hospital claim, have to be in the system. If your claim beats the hospital claim into the system, something they anticipated, they will issue what they're calling an interim denial to you. The problem is you won't know, based on the denial itself, whether your denial is an interim denial. In other words, not because they believe it's bundled, but because they simply don't know because they don't have the hospital claim, or it's a final denial because the hospital claim was in the system, they've determined that it was bundled, and therefore your claim is bundled. Now, in their original transmittal where they implemented this, CMS did say that they would reprocess the ambulance claim that's denied on an interim basis once the associated hospital claim enters the system. However, that didn't really happen. Some of the MACs have started to go back towards the beginning of this year and reprocess claims in April and May of last year. Other MACs basically threw up their hands and said you're going to have to appeal. So My advice to you, if you're sitting on open or denied SNF claims where you believe the denial is incorrect because you believe it should be excluded, if you haven't already, and if it's not too late, I would submit an appeal. At this point, that's probably your best bet to get someone at the MAC to look at it. It's not a perfect solution, though, for any number of different reasons, not the least of which is, well, the appeals themselves, the MACs are going to decide based on the common working file, and if the common working file isn't updated correctly, then there's nothing they can do. They're going to simply continue to deny them. That's why I think ultimately the resolution for our industry is to look back to the agreements with the SNFs. My guess is many of you use agreements, if you even have agreements, that probably don't get into much detail on the bundling. At best it says, to the extent it's bundled, I'll bill you, right? And as a result, you frequently end up in debates with the SNF about whether they're truly responsible or not. My suggestion would be actual contract language that avoids that issue entirely and just simply states that to the extent you've received a Medicare denial, that is adequate proof that it is their responsibility and therefore they are financially responsible. And then if you want, you can certainly add in language that says, but if and when Medicare reprocesses my claim and pays it, well, at that point, I'll refund you the SNF. But one of the things you need to just keep in the back of your head here is in order for your claim to be paid by Medicare, both the SNF and the hospital have to submit their claim, and they have to submit their claim correctly. This can cause problems, especially when you're dealing with trips that occur at or close to midnight, where the SNF doesn't actually suspend the SNF status, and that's what's triggering the denial, right? So you pick a patient up at midnight tonight or 11:30 tonight, you'll use today's date of service. The patient may not be seen in the hospital until 1 a.m. tomorrow. The hospital will therefore list tomorrow as its date of service. Well, there's not going to be an associated hospital claim on your date of service, and that's going to trigger a denial. Now, what should have happened is when the patient wasn't in that SNF at midnight tonight, the SNF should have suspended their SNF status. That would have allowed your claim to go through because the patient would no longer be within the SNF bundle period. However, the SNF's probably not going to do that. If for no other reason, they probably won't know the patient was out until the next day. Well, now you've created this catch-22 where your claim's being denied because the SNF is telling Medicare that they're in the Part A stay, and there's no hospital claim. Well, there is no adequate remedy other than billing the SNF in those situations, and changing that contract language can certainly help. The other thing this new edit has set in motion is just an increase in the overall volume of claims that get billed to the SNFs. So all of you have probably experienced in one way, shape, or form a situation where the SNF, you bill the SNF, they suggest that they're not responsible, you prove to them that they are responsible, and they still don't pay you, right? Well, in many cases, you've negotiated a rate that's less than your billed charge, right? The question is, what incentive does the SNF have to pay you, right? If they don't pay you and they string you along on the payments and you sue them, you can only sue them for the contract rate, right? Well, not such a big deal when it's only a handful of claims, right? But when it's 10x that number, right? And now we're starting to get into $10,000, $20,000, $30,000 that are past due. Well, it would sure be nice to have an additional remedy, right? So what I'm suggesting is, rather than going straight to the negotiated discounted rate, language that provides that your full bill charge is the contract rate, but then allowing for a discount down to a lower number if they make payment within a certain specified period of time. In other words, we're trying to build into the contract an incentive for them to pay you timely and a remedy for you if they don't. So what else is new? Well, Novitas won its rebid for MAC Jurisdiction H. That is Texas, Colorado, New Mexico, Oklahoma, Arkansas. I'm sure I missed a state or two in there, but if you're in one of those states with Novitas, they will remain your Novitas contractor, your Medicare contractor. The other big change that went into effect at the beginning of this year is the end of the transition period for the new Medicare cards. What that means is that as of January 1st, all Medicare claims have to be submitted with a valid MBI, Medicare Beneficiary Identifier. You can no longer use the old HICN number, HICN number. Hasn't really caused much of a controversy in our industry. I think most people were probably switched over into the MBIs fairly early on in the transition period. So this one, unlike the transition to, say, the MPI, has gone relatively smoothly. But it's possible that there are some claims out there that may inadvertently get submitted with the HIC number. So what you're seeing on the screen now is the rejection code that you will get if you submit a claim without a valid MBI. So you'll get category code A7 on your electronic claim, or a claim adjustment code, basically saying it lacks information. If you get that, more likely than not, the information that's missing is the MBI. So you may want to just, rather than drive yourself crazy trying to figure out what else you've forgotten, right, resubmit that claim with that MBI. Confirm that it's on there and then resubmit it. The ET3 program, in February, CMS published the list of ambulance providers, 205 of them that were selected to participate in the first year of the model. It's now going to release what it calls the NOFOs, or Notice of Funding Opportunity. That is money that's being made available to state and local governments or their designees that operate the 911 centers. One of the conditions of applying for that money was that you oversee a 911 area where at least one of the ambulance participants operates. So they needed to get the participants out first before they could then bid the NOFOs. Initially, their plan was to get the ET3 program up and running in May. However, as a result of the COVID issues, they recently indicated that they're going to push that back until the fall of 2020. So if you weren't selected, you'll have an opportunity to reapply for the second year of the program. It's unclear at this point whether or not that'll be a full year or a stub year. But for those of you that were elected to participate, well, everything's on hold until the fall. There's a bunch of other state legislative initiatives. None of these are really directly attributable to Medicare, but I do just want to sort of point out, because you're going to see some corollaries in what's happening on the state level with some of the initiatives that came out as a result of COVID, in particular as they relate to surprise medical bills and balance billing. One of the things that, and this is my personal pet peeve, is over time, the concept of a surprise medical bill has come to be conflated with the notion of a balance bill. The two are different, although they have certain elements in common. Technically, a surprise medical bill is a situation where the patient goes to receive care from someone that they believe is an in-network provider, but then ends up receiving ancillary services from someone that's out of network. The classic example is when you go to an in-network hospital for surgery. You vetted the surgeon, you've confirmed the surgeon is in your insurance network, but when you get there, you find out the anesthesiologist is not an employee of the hospital, but rather an independent contractor, and they don't participate in the insurer's network. That's a little bit different than a balance bill. Balance bill is really what happens in our industry, right? Balance billing is when you bill for the excess of your billed charges over the amount that's allowed by the insurance. So, one, it's not the same thing as billing for the copayments and deductibles, and this is an issue that's come up, especially with respect to the CARES Act provider relief funds, because in there they did indicate that you cannot balance bill. However, you can still collect for copayments and deductibles to the extent that those are still being assessed. I'm not going to go through the individual ones, but basically they're all trying to get at the concept of balance billing, especially in the air world. Almost all of these legislation, especially the ones that target air, will ultimately be struck down in court, in my opinion. There's a history of states trying to regulate air ambulance, and it's generally been unsuccessful due to the Federal Airline Deregulation Act. But they're getting more and more creative. So, for instance, the state of Wyoming essentially decided to extend Medicaid coverage to all state residents for air ambulance, regardless of the person's individual eligibility for Medicaid. CMS rejected that in January, and the state's still trying. North Dakota tried a different way. They banned the balanced billing, and then they also tried to ban subscription agreements. Now, what's interesting about this case is that while the court, in my opinion, correctly struck down the balanced billing ban as a violation of the Airline Deregulation Act, they did uphold the ban on the sale of subscription agreements, arguing that those are, quote, insurance, and therefore fall under state regulation, not federal regulation. So this may be sort of the new method that states sort of go after air ambulance, or at least attempt to regulate air ambulance. I'm not quite sure what they think they accomplished by banning subscription agreements, but it is what it is. In terms of the appeal backlog, we continue to see the overall time for appeals to be processed increasing, although the rate of increase is slowing down, or in sort of the terms we're using these days, we've flattened that curve. Now, this is the time from when you submitted an appeal to when it's heard. So it's a trailing or a lagging indicator. The current ALJ backlog has been reduced significantly. It's actually a 25% reduction as of the end of the fiscal year 2018, which ended in September of last year. In part, that's because of a federal court decision, A.A.A. versus Burwell. Basically, the court mandated initially, the American Hospital Association sued the government demanding that they honor the 60-day time limit that's in the regulations. In December of 2016, a district court rules in the AHA's favor and requires a phased reduction that you see here. CMS starts filing quarterly status updates, and they show that there's no way that they're ever going to meet those timelines. In fact, they show that the number of pending appeals actually starts to increase. CMS then appeals, not arguing that the lower court was wrong on the law, but simply arguing that it was impossible for them to meet the reduction, given the fact that A, they don't control their own budget, and then B, they're not allowed to offer mass settlements of claims. Keep that in mind. They argued that they were not allowed to offer mass settlements. Well, we go back, and ultimately the court finds, again, in the AHA's favor, and now demands an elimination of the backlog in 3 years. And interestingly said that if they fail to eliminate the deadline, the backlog, by the end of the fiscal year 2022, it would grant default judgment, meaning any provider with a pending appeal would automatically win that appeal. Well, now CMS certainly has the proper motivation to go about resolving the backlog, and it turns out they've actually started to make real progress. Conceptually, though, what they're doing is they're dividing their appeals into two worlds, those with high dollar amounts and those with low dollar amounts. Most ambulance claims, particularly on the ground side, will fall into the low dollar amount one. There, what they're doing are things like the low volume settlement initiative, where they just simply offer a mass settlement, right? On the higher side, so air ambulance claims and then non-ambulance claims in general, CMS wants some stake in it, and they want to be able to sort of look at the claim. So they're doing what they're calling negotiated settlements. So one of the big programs is the settlement conference facilitation. They've expanded that a number of times, most recently in June. Typically not an option for us because one of the requirements to participate in this is that the patient not be responsible if the appeal is denied. And since the majority of our appeals deal with things like medical necessity, where the beneficiary is responsible, we're not eligible. They then created sort of what they're calling SCF Express, which is for low dollar appeals. So appeals where all of the claims involved total less than $100K. And if the total dollar of your appeals are less than $10K, which will be the typical ambulance claim, unless you're bundling multiple claims at once, you must participate in the SCF Express. It's express in the sense that they handle it quicker. It's not really a negotiated settlement, though. Basically, they will just simply offer you a dollar amount as settlement in full. Now, they say they base that on certain data they have on their side, including the likelihood of your similar appeals being successful. But for now, from what we're hearing, is those appeals tend to be right around 60 cents on the dollar. So keep this in mind if you have appeals out there. Okay, and now we get to what I'm sure everyone was waiting for, which is CMS's response to the COVID pandemic. So they've done a couple of things. Well, they've done a lot of things, but they've done a couple of things that specifically get towards Medicare. So the first is they've approved for, at this point, I believe, every state in one way, shape, or form, 1135 waivers. These are the waivers that give states additional flexibility to do certain things. And while this doesn't typically contemplate a national public health emergency, it's usually used more for regional ones. So it will allow, for instance, out-of-state providers to more quickly be approved to be paid under state programs like Medicaid. It also allows expedited enrollments for providers that are coming from out of state. It'll waive state prior authorization requirements, as they might apply to, for instance, Medicaid. And for us, probably the most important in the current crisis is it allows institutional providers to provide care in alternative settings. So what we're really talking about here are field hospitals. So as a result of an 1135 waiver, your local hospital can create a new, quote, facility, maybe in a parking lot, maybe in an empty field. It might repurpose another building that it's leased, and then use that to provide care either as a stand-up ER, a triage center, an inpatient facility, et cetera. So, for instance, those of us that are in New York, the Javits Center was taken over and is being used to provide inpatient hospital care, right? The important thing for us to remember in terms of billing these, though, is that it's not changing the approved destinations. They're still not waiving them at this point in time. They will waive them in a separate program. But for these purposes, they're not allowing you to take them to an alternative site. Rather, they're considering that alternative site to be part of the hospital. And therefore, when you took them there, you took them to the hospital. That's what makes it billable under the 1135 claim waiver program. So as a result, you should use the H modifier for that field hospital, right? However, you're going to want to append this CR modifier to the back of that. So if it's an ALS emergency from the residence to this field hospital, A0427 R to H CR. What that CR tells them is not to correlate the destination address to a hospital because they're not going to find it in their system, right? So it tells them not to do their address check. But since it's part of the hospital, it becomes payable. Separate from that, they have waived or expanded the list of approved destinations. So as an example, Medicare historically does not cover transports from a residence to a physician's office for care, right? However, under this new waiver, any destination that's, quote, able to provide treatment to the patient in a manner consistent with state and local EMS protocols, and then they list a number of different facilities, will now be covered. So transports to that physician's office will now be covered, to an urgent care center will now be covered, et cetera. And next to each of them, what I've given you is the modifier that they're indicating should be used when submitting claims for each of them. So the physician's office remains a P. Essentially, all of the others become a D, which is for a diagnostic or therapeutic site. This is a true waiver of a previous program requirement. They've relaxed the patient signature requirement. So they've indicated that where it would not be practical to get the patient's signature or an authorized representative's signature due to the COVID precautions, that you can submit the claim based on that person's verbal consent. That would include situations, they said, where it would be impractical to decontaminate the tablet. So I think this would apply for most of you, right? And this is not known COVID, it's known or suspected COVID. That's why you're using the precautions. Now the question then is how you go about doing this. There's no right answer here, but the one I would recommend would be when you're using the patient's verbal consent to treat that as if the patient were signing their own disclaimer. So I would use the normal disclaimer language you use for the patient. The only difference would be rather than have the patient sign, I would have your crew member indicate patient's verbal consent obtained or similar words, right? If it's an authorized representative signing for the patient because they're physically or mentally incapable of signing, I would use the normal disclaimer language that you use for that authorized representative, and then use language such as authorized representative's verbal consent obtained, right? This just, because technically you're not indicating the patient's incapable of signing. You're indicating that rather than use a written signature, they've given verbal consent. Not entirely sure it will make a huge difference in the grand scheme of things, but I think it's probably best to be safe here and just do it, the way I was suggesting. They've provided a, quote, waiver of the PCS requirement. What they said is that when it would not be feasible to get the person to complete the certification, that they will not enforce the signature requirements. Now, I would be very leery of how you use this in your organization. It is not a waiver of the PCS requirement, period, end of statement, right? Only to the extent you simply cannot get the person to sign would it apply. And I think you would be hard-pressed to come up with a situation where it would be not feasible to get a PCS form. The reason I say that is because the physician could simply fax it to you, and there are no longer any COVID concerns, right? So, yes, it's out there. Yes, CMS has said that it may apply to ambulance services, but I would be leery of using it unless you have absolutely no other options. In other words, as a last resort, it's one thing, but I certainly wouldn't be viewing this as a license to simply not get PCS forms at all. And especially for the repetitive patients, I think CMS will ultimately be less than, I think they're going to be hard-pressed to accept that it's just simply impossible to get it for a repetitive patient, especially since it can be emailed or faxed. Medical necessity, and this is the big question. CMS has declined to affirmatively state whether isolation precautions meet medical necessity. What they posted is a Q&A where they indicated that, quote, the medical necessity requirements have not been changed. Now, they've also told people to apply common sense, and that's the problem here is we're not really so much asking for a waiver of the medical necessity so much as them to say that medical necessity would be met in that situation. And unfortunately, CMS, I think, is hesitant to give such a blanket affirmation. I think they believe that it would lead to fraud and abuse, and while I'm sure it will certainly lead to some level of abuse, I think their concerns are overstated, especially wrapped, when viewed in the larger context of all of the various precautions state and federal governments have taken with regards to the COVID. So what I would be looking to instead is to your local public health officials for clarity on this. If they mandate the use of an ambulance for the transportation of known or suspected COVID patients, I think that would create an argument that legal prohibitions contraindicate other means of transport. So, for instance, those of you in Florida, the state Medicaid agency has indicated that isolation precautions would meet its medical necessity requirements. Now, that doesn't mean Medicare has to go along, but it certainly would create an argument there. Waiver of cost-sharing amounts. Just a little bit of confusion here. CMS has waived the cost-sharing and deductible that would be applicable to COVID testing. In fact, they didn't really waive it because there wouldn't have been a copayment or deductible for clinical diagnostic lab tests anyway. But that's been interpreted in a number of publications incorrectly to say that they're waiving the co-insurance and deductible for any service that's ancillary to COVID testing, which would presumably include our transports to get the test. CMS has actually stated quite clearly that they are not waiving the coinsurance and deductibles. They will still be applied, and you can still collect them, regardless of whether or not you've taken provider relief funds in either the first or second tranche. Now, that being said, while Medicare fee-for-service has not waived the cost sharing, most of the major commercial insurers have, including all of the Blue Cross entities, Aetna, United Healthcare, Humana, et cetera, and those waivers have extended also to their Medicare Advantage programs. So just be mindful when you get remittances back from plans that there may be a change in the cost share. They've suspended most medical reviews, including the targeted probe and education TPE reviews, for the duration of the public health emergency. Now, in terms of financial relief, CMS initially expanded its accelerated and advanced payment program to extend to basically all providers. What that allows you to do is to borrow up to 3 months of your historical medical payments today, not pay it back for 4 months, and then starting in month 5, they would offset against future payments the amounts that you've were advanced, so that after month 5, 6, and 7, presumably your balance would be back to 0. This was intended to address the cash flow issues that had resulted, especially those healthcare providers and suppliers that initially abided by the stay-at-home orders and therefore didn't necessarily have their billing folks in the office to submit claims. Now, they've since recently, as in last week, announced that they would no longer be accepting new applications for advanced or accelerated funds, indicating that rather than go through the Medicare program and advanced funds, they believe that the relief that's available under the CARES Act to providers accomplishes the same goal. Then we get to the provider, the CARES Act relief funds themselves. So it's $100 billion, and then it's supplemented by an additional $75 billion in the stimulus 3.5 bill. The first $100 billion they've indicated how they will distribute it. It's $50 billion in general allocation funding, another $10 billion to hospitals in those areas that are particularly affected by the pandemic, $10 billion for rural health clinics and hospitals, $400 million for the Indian Health Service, and the balance of $29.6 billion will be used for the uninsured, SNFs, dentists, and providers that only participate in Medicaid. They haven't yet indicated how they will allocate that $29.6 billion between their uninsured fund and the other, what they're calling, additional allocations. Now, the general allocation funds, they did in 2 tranches, with the first tranche going out April 10th through April 17th, and then a second tranche that started last week. Ultimately, their goal was to distribute the $50 billion to all healthcare providers using a formula so that the amount of money you got would be in rough proportion to the percent of total 2018 net patient revenue that your 2018 net patient revenue represented. So, and they estimate that the total net patient revenue is $2.5 trillion. So, using some basic math, if you assume a very large healthcare provider that had total revenues of $25 billion, if I'm doing my math right, that would represent 1% of all healthcare spending in 2018, and therefore they would expect ultimately to get 1% of the $50 billion, or if I'm doing my math right, $500 million. Now, in order to get the first tranche of funding out as quickly as possible, HHS used the only data that it had in its possession, and that was Medicare fee-for-service payments. So they based their initial tranche on your relative percentage of total 2019 Medicare fee-for-service spending. So going back to my earlier example, if that large provider received $400 million in tranche 1, they would then calculate that its balance is $100 million and then roll that out in the second tranche. However, it is possible that a healthcare provider might have received more money in the first tranche than its total share would have been based on 2018 net patient revenue. In order for that to happen, basically the provider has to have its revenues be comprised of a greater percentage of Medicare dollars than a typical or the average healthcare provider, right? Now, in our industry, that is very possible. It's not unusual in our industry for 50% of a company's revenues to come from Medicare, in which case many of you have done the calculation and you've figured out that based on their calculation, you would have a negative number. And what that would seemingly suggest is that you may not be getting a distribution in the second tranche. I don't know at this point if that is necessarily true or not. I would still apply nonetheless. I have two arguments for it, or three really. The first is there's really no harm in applying. Yes, they will require you to give up balance billing, but if you accepted the first tranche, you've already agreed to give up balance billing, so it doesn't really cost you anything other than the small amount of time to fill out the portal. Two, the formula they use may ultimately change. It did with the first tranche. Most of you probably got more money than you were expecting based on the original announced formula that worked out to about $62,000 for every $1 million in Medicare money. And the third is it is possible that they may condition future relief funds on your participation in earlier relief funds. So, one way to look at it would be if you took the off-ramp in round 2, they may interpret that to mean you don't need the money and therefore not include you in a potential round 3. So even if you think your numbers are going to be negative and therefore you won't get anything in the second tranche, I would still fill it out. Now, the uninsured. An undisclosed portion of the remaining 29.6 will go to reimburse the uninsured at Medicare rates subject to available funding. So what that means is it's first come, first serve. So they opened the portal to enroll on April 27th, and claims may be submitted starting on May 6th. So if you intend to submit claims for this program, my suggestion would be to get enrolled now, and my suggestion would be to submit them as early as possible once the portal opens on May 6th. The estimate or the best guess is that while they'll allocate the bulk of that $29.6 billion to the uninsured, it will likely go very quickly. You're seeing estimates out there of 24 to 48 hours before the funding will be exhausted. So certainly I would be quick in getting these in. Now the website indicates that it's for COVID testing and the treatment of confirmed COVID-19 diagnosed patients. Now what's unclear at this point is that whether that's by design, it's intentional, or whether or not it's just sort of loose language on the part of HHS trying to put out these things, very quickly. So most of the other programs they've provided funding for speak to known or suspected COVID or presumed COVID. Now in this case, they're saying confirmed COVID diagnosis. So unclear whether or not it will apply to those with suspected COVID. Now, on their call yesterday, one of the presenters for HHS said yes, it would, but again, it's unclear whether or not that person is speaking on behalf of the program itself, or not, whether or not everyone is just sort of trying to come up with their best guess about what HHS means at any given point in time. A couple other things to mention here. You will be required before submitting a claim to certify that you've conducted the proper eligibility check so that you know with certainty that the patient is in fact truly uninsured. And then it sort of raised the question of what that means. So you are not going to be able to submit a claim for a John Doe, right? You're going to, at a minimum, likely need to know their name, their date of birth, and their social security number in order to submit a claim for them, right? And then likely it will be a representation that you checked eligibility and were not able to find any insurance. I don't think that they're actually going to necessarily ask you to upload those eligibility checks, but they would reserve the right to come after anyone that submits claims without providing the proper level of due diligence first. So we do have a question, and that's whether or not treat without transport claims are going to be reimbursable under the new uninsured program. I don't know is the answer. You're right, there is currently no reimbursement for treatment at the scene. However, I think the issue would boil down to if it's limited only to those with known COVID diagnoses, anyone that you're treating at the scene and not transporting likely wouldn't be tested and therefore wouldn't be confirmed to be COVID positive. Yes, I realize that you may respond to someone that's staying at home after being diagnosed, but at this point, honestly, we don't know the answer. My best guess at this point is that no, they're not in a position to accept treatment at the scene for EMS providers. All right, let me keep going, and then we'll get to the questions. Okay. As a reminder, the 2020 Medicare Reference Manual is now available. I think the author is wonderful, so I encourage all of you to take a look. But for those of you that are AAA members, $200. For those that are non-members, $400. It's also an ebook, so you're going to get the ebook now if you buy it, which you can use, and then we'll ship the physical ones, once we get that portion of this up and running. But for those of you that have bought the book in the past, I hope you'll agree. It was written with the intent of answering many of the questions that come up, over time, and it's added to every year based on new issues that pop up. The intended audience was a new hire at your shop who has almost no background in ambulance billing, with the idea that if they were to read through that, presumably they would have a rough sense of what the coverage is, the modifiers that we use, and some of the vocabulary that we use, and that would allow you to immediately plug them in and start, contributing to the organization. So I encourage everyone to consider buying that. If you are interested, you can certainly do so through the AAA's website. And with that, I guess we'll turn to the questions. So one of the questions was, for the second round of COVID-19 funding, you must upload a tax return. Local governments, how do we do that? So actually, I have an answer for you. On Friday, when the portal opened, we immediately spotted this issue, and we called the hotline. And I stayed online with a nice gentleman for 2 hours, and we made several important breakthroughs. After about an hour and a half, I believe he then understood what the government was. And after another 30 minutes, I think I managed to convince him that it was theoretically possible for the government to run a healthcare provider. Turns out he has a fire department where he lives. So it wasn't a productive call. I did get a call back today, and they confirmed what we already knew, which was HHS indicated in a frequently answered question that came out on Monday that if you're a governmental entity, you would select the tax-exempt organization and then upload your most recent audited financials, whatever year those are, if you don't file tax returns. Another question with regards to the uninsured COVID program. You can only submit claims. Can you only submit claims where you absolutely know they will have a positive COVID test versus presumed or under investigation cases? I don't know the answer to that question. If you read HHS's description of the program, they say it is for COVID-related testing or the treatment of individuals with a COVID diagnosis. By contrast, the other relief funds spoke to presumptive COVID. So what we don't know at this point is whether or not that is by design and that they intend to limit it only to those patients with COVID, or whether or not this was just someone doing something very quickly on a Friday and trying to get it out. please keep in mind that these summaries that HHS puts out are not written with us in mind. They're typically written with the hospitals and doctors in mind, and in their case, they would ultimately know what the patient's diagnosis is. So at this point in time, it is our belief, based on what their presenter said yesterday, that it would apply to suspected COVID transports, but we don't know for sure. I have a couple more questions, and I'll try and get through. As a reminder, if you have a question, please feel free to submit them there in that chat box, and the question and answer section, and we'll get to them when we can. So, next question deals with verbal consents for signatures. Is it only for suspected or positive COVID, or for all patients? They didn't say whether it's. They didn't base it on the patient. They based it on whether or not it would be impractical under the circumstances for you to get the signature. So, given that you don't know if they're positive or not, you therefore have to decontaminate the vehicle anyway. I would interpret it as, in our industry, as applying to everything. Next question is whether or not we should be billing Medicare Advantage plans for the alternative sites and the expanded modifiers. I would, although we're not hearing great reviews in terms of their ability to process them at this point. I think a lot of them were relatively slow in getting their systems updated. But yes, I would be submitting them. Technically, they're supposed to follow Medicare's coverage rules. I think this goes back to the uninsured program and the issue of COVID versus presumed COVID. And the question was, so should we send them in and let CMS sort it out? I would. But, we may get additional guidance in the next day or two. Keep in mind we've got about a week before that program launches, and I suspect that there'll probably be some updates before then. What if the patient has Medicare Part A that doesn't cover ambulance transportation? Will that qualify as uninsured? Unfortunately, the answer is no, they are not uninsured. This is intended for those individuals without insurance. So similarly, and it wasn't your specific question, but it's been asked in other forums, what about a patient that has an unmet deductible? Will that render them uninsured for the purposes of the program? Unfortunately, no. They're responsible for the deductible. However, most plans are waiving them for COVID-related, so presumably should not be an issue going forward. Couple additional questions. Where do I find April 10th CMS release regarding medical necessity? If you go to the easiest way, if you're a AAA member, is to look back to a member advisory that I wrote on April 11th. We will link to that. If not, it's in a larger document called Medicare Fee-for-Service Frequently Asked Questions for COVID-19. If you Google that, it should take you right there. And then there's a question, should the CR modifier be used on all transports if the patient is PUI or suspected and they're going to a normal ER? The CR modifier is used when a claim is covered based only on the presence of an 1135 waiver. So it is not an issue. It doesn't really have anything to do with the patient's COVID status. It has to do with where they're going. So if they're going to the previously existing hospital structure, you would not use the CR modifier because that destination is covered regardless. If they're going to a temporary field hospital, then yes, you would use the CR modifier. I wonder, though, if the person that asked the question is confusing the CR modifier with the CS modifier, which CMS is sort of alluding to should be used for COVID cases. However, its use doesn't really impact our claims. It's really more for the physicians that are trying to get the co-payment waived for the test. So in sum, use the CR if you took them to a field hospital that's affiliated with a normal hospital, but not the original hospital building. If you take them to the original hospital building, just use your normal modifiers. Another question that came in is, we've received a request for repetitive patients due to isolation precautions, and the non-emergency medical transportation is refusing to accept. Based upon your previous slide, should we obtain a PCS from the attending physician documenting COVID positive and requiring isolation during the transport? Mike, that's a decision you're going to have to make. I am not, well, just because the non-emergency providers are refusing to take them doesn't mean it meets the medical necessity requirements for an ambulance. So you're going to have to make the determination on whether or not you're comfortable taking that risk. CMS has said that they are not waiving the requirements, and there is no clear guidance on whether or not isolation meets medical necessity. If, however, you are going to transport them on a repetitive basis, then yes, you would need a signed PCS signed by the doctor. For the uninsured program, just confirm your expectation that the funding will be quickly consumed, and therefore that there should not be an expectation on receiving funding on claims submitted in June or July. Yes, I anticipate that the funding will be exhausted quite quickly, and therefore I do not anticipate it being around by the time June or July rolls around. However, there is another $75 billion out there, and there may be additional rounds of funding. So I don't know what the future holds. I anticipate that where we are today is not the end of the discussion in terms of additional provider relief coming from HHS or CMS. The only thing I'll say is, if I'm wrong and the money is still there in June or July, great. But if it's not, I wouldn't be holding the claims that you already have, waiting for future ones. So deal with what we have in front of us, get those in on May 6th, and then if and when there's another program, or if and when there's still money, we can worry about the uninsured that come in June or July. And I know we ran a little bit long, but I have there are no more open questions. So with that, I thank everyone for their time. And Megan, do you want to close us out?
Yeah, sure. Well, thank you so much, Brian, and thanks everyone for joining us today. As we mentioned earlier, I'll go ahead and send out an email this afternoon with a recording of the event today and the PowerPoint slides, and I'll include some links of requested resources that a couple people had asked for, as well as a list of some of our other upcoming AAA webinars. But that is it for today. We thank you guys for joining us. I know you're all extremely busy. We hope you have a great rest of your day. Thank you.